Cardiac function. So cardiovascular disease, by definition, the cardiovascular disease refers to a group of disorders that affect the heart and blood vessels. The significance is it is a leading cause of morbidity and mortality worldwide. Prevalence, general population prevalence, so cardiovascular disease affects individuals of all ages, but is particularly common in older adults. The majority of people over 60 years old are affected by some form of cardiovascular disease. Due to the aging population, managing and preventing cardiovascular disease is a big public health challenge. There are four major types of cardiovascular disease. So the first one is coronary heart disease. That affects the blood supply to the heart muscle. Cerebrovascular disease, which affects the blood flow to the brain. Peripheral arterial disease, which affects blood vessels in the limbs, often causing pain or mobility issues. And then the last one is aortic atherosclerotic disease, which involves the aorta, the main artery from the heart, and can lead to aneurysms or rupture. So, clinical manifestations, the coronary heart disease may present as a myocardial infarction, commonly known as a heart attack. It occurs when blood flow to part of the heart is blocked. Angina pectoris, this is chest pain caused by reduced blood flow to the heart. Heart failure, the heart becomes too weak to pump blood effectively. And sudden cardiac death, this is unexpected death caused by heart dysfunction, often due to arrhythmias. Cerebrovascular disease manifests as a stroke. It occurs when blood flow to part of the brain is blocked or a vessel burst. So transient ischemia attack, often called a mini stroke. It's a temporary blockage with a stroke-like symptom that resolves within 24 hours. So really, it's kind of a burden to the emergency department. We have about 7 million people that visit the emergency department each year due to chest pain or related symptoms. Of those 7 million people, 15 to 25% are diagnosed with acute coronary syndrome, which is a critical manifestation of coronary heart disease. As mentioned, it's a high burden on emergency systems due to time-sensitive nature of cardiac events. Just a little side note, many patients present with nonspecific symptoms like chest pain or shortness of breath, and that requires rapid triage and diagnostic workup. So that's kind of where they're saying that burden can come from. And then we have acute coronary syndrome. It's an umbrella term for a range of urgent heart conditions caused by sudden reduction in blood flow to the heart. So types of those would be a ST elevation myocardial infarction or a STEMI, a non-ST elevation myocardial infarction, and unstable angina. These are caused by plaque rupture, thrombosis, or severe atherosclerosis in the coronary arteries. This is a life-threatening emergency and a major driver of morbidity and mortality. Diagnostic approach to chest pain in the ED. So common symptoms people come in with: chest pain, shortness of breath, dizziness, fatigue. Luckily, we're here to help. Labs tests can help differentiate cardiac versus non-cardiac causes. So we come in and we can run a troponin level. That's the marker for myocardial injury. We can also run a BNP or a pro-BNP to assess for heart failure. EKGs can be ran as well for ischemic changes. We can also run a D-dimer in the lab, and that helps to rule out a pulmonary embolism, if it's suspected. So pathophysiology of the atherosclerosis. Atherosclerosis is an underlying cause of most cardiovascular diseases, including stroke. So the definition is it's a chronic inflammatory process where cholesterol-rich plaque builds up inside the arteries. So we kind of have some steps here. We have endothelial injury from hypertension, smoking, having a high LDL, and then the lipid accumulation starts, and then there's a formation of fatty streaks. And then we have inflammatory cell infiltration and the plaque development starts. And then that's when the plaque ruptures or erosion happens, which leads to the thrombus formation and vessel occlusion. And basically that results in a reduced blood flow to ischemia to an infarction if it has been prolonged. Cardiac biomarkers continued. So we've got some crucial for distinguishing unstable angina from a myocardial infarction. It's measured in all patients presenting with chest pain or dyspnea. So the key biomarkers, as mentioned, is a cardiac troponin. We have cardiac troponin T and I. I believe we'll get into these in a little bit, but here's some info for now. This is the most sensitive and specific. It elevates within 3 to 6 hours of myocardial injury, and it will peak at about 24 hours, and it's going to remain elevated for days. So there's that. See, when we have the universal definition of myocardial infarction, is to diagnose myocardial infarction. And to do that, you have to have at least one of the following clinical signs. So you have to have chest pain. You have to have new EKG changes, maybe having some imaging evidence of new loss of viable myocardium, or an identification of a coronary thrombus via an angiography or an autopsy. And they have to have elevated cardiac biomarkers, preferably the troponin, with a rising and/or falling pattern in at least one value above the 99th percentile upper reference limit. So as we were talking, those biomarkers for a myocardial infarction, the cardiac biomarkers are used to detect myocardial injury by measuring proteins released from damaged heart muscle cells in the bloodstream. So cell death or necrosis in the myocardium causes the release of intracellular proteins into circulation. So we were able to measure these proteins, which can help diagnose and manage myocardial infarction. So obviously some clinical importance and why it matters is we're able to confirm the diagnosis of myocardial infarction. We can estimate the timing of the cardiac event. We can help assess the severity or extent of the myocardial damage. And they can also help guide the clinical decision-making and treatment for the patient. Initial biomarkers that were originally used was the AST and the LD. These enzymes, unfortunately, were not specific to the heart, so they were found in other multiple tissues like liver and muscles. So that kind of made them a little less reliable for cardiac-specific diagnosis. So then we had some improved biomarkers, which was the CK, or the creatine kinase, sorry. It was found in tissues, brain, muscle, heart, but they also found that it rises within 4 to 6 hours of the myocardial infarction. And then we also have the CKMB, which is the creatine kinase myocardial band. That is more specific to cardiac muscle than the total CK. It rises in about 4 to 6 hours, peaks at about 24 hours, and then it'll normalize again back down about 48 to 72 hours afterward. And then we have the good old troponin. We have troponin TNI and TNT. These are considered the gold standard in the modern myocardial infarction diagnosis. They are highly cardiac specific and sensitive. They will rise within 3 to 6 hours, peak at 12 to 24 hours, and they're going to remain elevated for about 7 to 10 days. They can help detect even really small infarctions. So we just need to remember, troponins are kind of the new preferred biomarker for diagnosing because of their high sensitivity and specificity to cardiac-only tissue. Creatine kinase. It is an enzyme involved in cellular energy metabolism. It's found in all striated muscle, including cardiac muscle, skeletal muscle, and the brain. So after myocardial infarction, CK is released into the bloodstream due to cell membrane damage. So in patients that have had a myocardial infarction, CK levels exceed normal ranges within about 6 to 8 hours, peak again about 24 hours, and they're going to return to normal about 3 to 4 days later. Peak levels can be 2 to 10 times higher than normal, depending on the size of the infarction that happened. CK, unfortunately, is present in all types of striated muscle, so not just the heart. Therefore, an elevated total CK is not specific just to cardiac or heart injury. It could also be because they have some skeletal muscle injury, if they'd had seizures, brain injury, or have done some intense exercise that can all cause, an increase in the CK. The CK exists in 3 isoenzyme forms. You have a CKMM, CKBB, and CKMB. Each of these are associated with specific tissue types and clinical significance. So the CKMM is found mainly in skeletal muscle, and its levels will increase in the blood following muscle injury or strenuous physical activity. So if they've had like a trauma or an intense exercise or certain muscle disorders, that can cause increases. CKBB is predominantly located in the brain tissue, and elevations in the CKBB are typically going to be observed in cases of people who have had a brain injury or stroke. And the CKMB, this is the most relevant isoenzyme in cardiology. As far as the CKs are concerned, it's found mainly in cardiac muscle, and its elevation is associated with myocardial damage. CKMB is especially valuable in the diagnosis of myocardial infarction and is considered more specific to heart than total CK, as mentioned. So for diagnosis, like we mentioned, it's more cardiac specific. It's used to help support myocardial infarction diagnosis, especially when troponin is not available, or to detect a reinfarction as it returns to normal faster than troponin. So CKMB rises and falls in a pattern very similar to the total CK. It rises 4 to 6 hours after, peaks about 24 hours, and then it will go back down to normal about 2 to 3 days. Cardiac troponins. So troponins are a group of 3 regulatory proteins involved in muscle contraction in cardiac and skeletal muscle. So in cardiac muscle, the troponin complex is going to play a very critical role in calcium-mediated regulation of contraction. The complex is composed of the troponin T. That anchors the troponin complex to the tropomyosin, which helps maintain structural alignment. The troponin I, which inhibits the interaction between actin and myosin, thereby preventing contraction at rest. And then troponin C binds to calcium ions, which reverses the inhibition caused by T and I and initiates muscle contraction. So TNI, or troponin I, is a highly cardiac specific marker. It is normally present in very low concentrations in the blood. Normal, reference range is less than 10. In patients with an acute myocardial infarction, TNI levels rise significantly, often exceeding, 100 or more. Levels will begin to rise within 3 to 6 hours after they've had a myocardial infarction. Peak will be about 12 to 24 hours, but again, it's going to be, remain elevated for about 7 to 10 days. So let's see here. We've got cardiac troponins are highly specific to myocardial tissues, of course, unlike some other markers like CK, which may be elevated in other non-cardiac conditions. So their elevation is a direct evidence of myocardial cell damage, making them kind of the gold standard for diagnosing myocardial infarction. Troponin testing not only confirms the presence of myocardial injury, but also helps to assess the severity and the prognosis. Troponin I and T are released into the bloodstream following myocardial cell injury and serve as highly specific markers for such. After myocardial injury, as mentioned, the cardiac troponins become detectable in plasma within 3 to 12 hours. Again, will peak at 12 to 24 hours and then remain elevated for a few days. Now, TNT can remain elevated for 8 to 21 days, and TNI can remain elevated for 7 to 14 days. So this extended window of detection can help allow clinicians to diagnose myocardial infarctions even in patients who present days after their symptoms start. So due to their high sensitivity and specificity for cardiac tissue, cardiac troponin I and T is currently the preferred biomarker for diagnosing myocardial necrosis. These proteins are now the gold standard, once again, for confirming myocardial infarction and are superior to older markers, as mentioned before, like CK or AST. Current clinical guidelines recommend drawing a troponin specimen as soon as possible after the onset of symptoms that are suggestive of myocardial infarction. And then we're going to do serial measurements. So we're going to do it again at 3, 6 hours, 9 hours. We're trying to detect a rise and or a fall pattern, which is diagnostic of an acute myocardial injury. So while troponins are the first-line biomarkers, CK-MB remains the next best alternative for diagnosing the myocardial infarction, particularly in situations where troponin testing is unavailable or when assessing for reinfarction due to its shorter half-life. So in contrast, total CK is no longer recommended for diagnosing myocardial infarction, just because it doesn't have that cardiac specificity and can be elevated for other reasons. There is a chart on the next slide that helps visualize the rise and falls of these cardiac biomarkers. Then we move on to BNP. So shortness of breath. It's a common presenting symptom in patients with heart failure, but it is considered nonspecific. Dyspnea, which is shortness of breath, can result from various conditions, including pulmonary disease, anemia, infection, anxiety even. So it can make it challenging to determine the underlying cause based on symptoms alone. The role of the natriuretic peptide in diagnosis of this, so it can help distinguish cardiac from non-cardiac causes of dyspnea. Clinicians often measure the BNP, not to be confused with BMP, it says N as in Nancy, or its inactive precursor, the NT-proBNP. These natriuretic peptides are released by the heart, specifically the ventricles, in response to increased pressure and volume overload, which is a hallmark of heart failure. Both BNP and proBNP are valuable tools in the diagnosis of ventricular dysfunction, and their levels correlate with the severity of heart failure. So elevated concentration of these peptides not only assist in confirming heart failure as the cause of dyspnea, but are also useful in predicting morbidity and mortality in affected patients. So the higher the levels are generally associated with the worst outcomes and increased risk of hospitalization or death. And then we move on to CRP, or C-reactive protein. CRP is a marker of inflammation. It is an acute phase protein and a widely used biomarker of systemic inflammation. It is produced by the liver in response to pro-inflammatory cytokines, especially interleukin-6. In the context of cardiovascular disease, the CRP has emerged as a great tool for assessing both inflammation and risk. So inflammation plays a central role in initiation, progression, and destabilization of atherosclerotic plaques, making it a key contributor to coronary heart disease. As an inflammatory biomarker, CRP reflects the underlying inflammatory activity associated with atherosclerosis even before clinical symptoms can develop. So in healthy individuals, CRP's levels are typically less than 10. If they are in an acute inflammatory state, levels can increase by up to 1,000-fold. In a cardiovascular medicine, mild to moderate elevations are considered clinically significant and may indicate increased risk of future cardiovascular events. So we also have high sensitivity CRP now assays. They're often used in cardiovascular risk assessment as they can detect low levels of inflammation that are relevant to the atherosclerosis. So CRP is now recognized not only as a marker of active inflammation, but as a predictor of coronary heart disease. Elevated CRP levels have been associated with a higher risk of myocardial infarction, stroke, and peripheral arterial disease. And it is often used alongside with other risk factors like cholesterol, high blood pressure, in the risk stratification risk tool. And then we move on to homocysteine. This is a sulfur-containing amino acid that is normally present in plasma. It is produced during the metabolic demethylation of methionine, which is an essential amino acid that is found in dietary proteins. Under normal conditions, homocysteine is rapidly metabolized through pathways that require folate, vitamin B6, and vitamin B12 as cofactors. There's been a lot of evidence anyway that has linked elevated homocysteine levels to an increased risk of cardiovascular disease. While extremely high levels of homocysteine, like greater than 100, are rare, they are strongly associated with accelerated atherosclerosis and vascular damage. Even mild to moderate elevations in homocysteine have been shown to correlate with a higher risk of coronary artery disease, stroke, and peripheral vascular disease. Elevated levels may contribute to endothelial dysfunction, oxidative stress, and prothrombic states, all of which can play a role in atherogenesis. As far as genetics are concerned and nutritional stuff, some individuals may have a reduced ability to metabolize homocysteine due to genetic variants or nutritional deficiencies. This impaired metabolism can lead to premature coronary artery disease, even in the absence of traditional risk factors like hypertension or hyperlipidemia. Clinical use for homocysteine testing, although it's not a routine cardiac biomarker like troponin or BNP, homocysteine measurement may be considered sometimes for patients with premature coronary artery disease, if that patient has a strong family history of coronary vascular disease, unexplained thrombotic events, if there's suspected vitamin deficiencies or malabsorption as well. So its role is more in risk stratification and long-term prevention rather than diagnosing acute myocardial infarctions.